Good afternoon. Thank you. Thank you very much. Please continue to enjoy your lunch. We hope you've had an informative day so far, and we think that this next session will be particularly relevant to some of the challenges we're facing in the world of health policy. A lot has happened since last year at our summit, and we have two national experts with us that are going to break down some recent policy changes that have happened at the federal level. Just to give you a little bit of background, the state budget bill, which was introduced in March of this year, included a provision that would trigger the end of the Medicaid expansion coverage for about 700,000 Ohioans if the federal government reduced the amount of its contribution to that program below 90%. For several months, it wasn't clear whether H.R. 1, which is the federal reconciliation bill that's also known as the One Big Beautiful Bill Act, would reduce that federal match or federal contribution or not. In the end, it didn't. So for now, Medicaid expansion remains in place in our state. Yet, there were many other policy changes that happened in H.R. 1. And that will have an impact on Ohioans who have Medicaid coverage and those who serve those Ohioans. So that's what we're going to dive into this afternoon. Again, we have two national experts with us who are going to share their wisdom about what that bill contains and its relevance to state health policy making here over the next several years. First, we have Adam Searing, who's an associate professor at the Georgetown University McCourt School of Public Policy Center for Children and Families. There, he focuses on Medicaid and other health coverage programs. Before joining the center, he was the director of the Health Access Coalition for the North Carolina Justice Center for 17 years. In addition, he's taught public policy courses as an adjunct faculty at both the University of North Carolina and Duke University. He's a licensed attorney with degrees in both law and public health from UNC Chapel Hill. And then we also have Jennifer Tolbert with us. Jen is the Deputy Director on Medicaid and the Uninsured and the Director of State Health Policy and Data for KFF. She directs research and policy analysis on Medicaid eligibility and enrollment policies, as well as access to and the affordability of coverage for low-income populations. In addition, she manages State Health Facts, which is a source for state-level data on over 800 key topics. Raise your hand if you've ever used State Health Facts. Yes. So prior to joining KFF, Tolbert served as the Assistant Vice President for Policy at America's Essential Hospitals. And before that, she worked in the Office of the Assistant Secretary for Planning and Evaluation at the U.S. Department of Health and Human Services. She holds a bachelor's degree from the University of Virginia and a master's degrees in both public health and social work from the University of Michigan.
I grew up an Ohio State fan, so.
All right, so they're both going to provide a few brief remarks about particular provisions of H.R. 1, and then we're going to have a conversation where we'll dive into more detail. Please be noting your questions during their remarks, because we will make sure we have time to address questions from the audience. Oh, and then you need to.
Okay. I'm going to come up here. And, okay.
I forgot we just agreed.
Yeah. Well, thanks, Amy. It's a pleasure to be here. And let's see.
There we go. Okay. So I'm just going to talk from up here, but I'm going to talk pretty quickly, try and go through some of the key provisions in the new law. I won't be able to talk about everything because there is a lot of changes, but I'm happy to entertain any questions. And if I don't have the answer, I'm sure my colleagues at KFF will. So with that, let's dive in. Okay, so the reconciliation law, or One Big Beautiful Bill, H.R. 1, I think we'll stick with H.R. 1 because that's the easiest reference here, obviously made a number of significant changes to the Medicaid program and will cut federal Medicaid spending by about $1 trillion over 10 years. Now, the cuts hit hardest on states that expanded Medicaid through the Affordable Care Act, and over the provisions that target expansion states or expansion enrollees account for $526 billion of the $1 trillion in cuts, so over half of the cuts. And I will note the single largest source of federal spending reductions is the Medicaid work requirements, which accounts for $326 billion of the total $1 trillion in cuts. So the Congressional Budget Office has estimated that about 10 million people will lose coverage over the next 10 years, so by 2034. 3/4 of the coverage loss will come as a result of changes to the Medicaid program, and over half, or 5.3 million people, are expected to lose coverage because of the Medicaid work requirements. And I'll just note that although the Congressional Budget Office does not provide state level estimates, at KFF we kind of allocated these increase in the uninsured across states, and we estimate that 340,000 people in Ohio will be newly uninsured in 2034, and of those 290,000 will lose coverage because of the Medicaid changes. So there are a number of key changes to Medicaid. I'm going to talk in a minute and drill down a little bit on the work requirements, but just to provide a bit of an overview of some of the changes that are going to affect Ohio. So the law makes changes to eligibility for Medicaid in a couple of key areas. It restricts, in addition to imposing work requirements, it also increases the frequency of eligibility determinations for people who are enrolled through the expansion pathway to 6 months instead of every 12 months. And I'll just note that when you increase the frequency of eligibility determinations, that ends up being a point at which people will lose coverage. It also restricts eligibility for immigrants on Medicaid, eliminating coverage for asylees and refugees, among others. The law also imposes or requires states to impose new cost sharing on expansion enrollees with incomes between 100 and 138% of poverty. Now, I'll note that Ohio already has some cost sharing requirements for this population, but the law will require the state to broaden the scope of services that will be subject to these co-payments. So expansion enrollees in this income group will now have to pay co-payments on a much broader set of services. The law also takes aim at some of the mechanisms by which states raise their share of Medicaid spending. So it ratchets down states' abilities to use provider taxes, as well as this convoluted term called state-directed payments, which is just payments that states make to managed care plans that they then direct onto providers. So they basically, it's a way to enhance payments to certain providers, but the state does that through the managed care plans. And so the law will restrict the ability of states to use these financing mechanisms going forward. And Ohio does have both provider taxes as well as these state-directed payments that will be affected by the law. Okay, so I want to turn to the work requirements, because again, this is the single largest source of coverage loss as well as federal spending reductions. So beginning in January of 2027 or earlier at state option, states will, individuals who are enrolled through the expansion group, as well as individuals in partial expansion waiver programs in Georgia and Wisconsin, will have to begin meeting work requirements as a condition of eligibility. So individuals will need to work 80 or more hours a month or participate in work-related activities like community service or be in school half-time. Now, the law does specify, specifically exempt certain individuals from these requirements, including parents of children ages 13 and under, individuals who are in a substance use disorder treatment program, as well as those who are medically frail. The state will also have the ability to allow for certain hardship exceptions for individuals in certain circumstances, including individuals who have been recently hospitalized, as well as individuals who live in areas with high unemployment rates. And I will note, we just did an analysis of the potential impact of this exception for individuals who live in counties with high unemployment rates, and number of quite a few individuals in Ohio counties across the state could be exempt if the state takes up this option. It is optional to the state, and so those individuals will only be exempt if the state chooses to pursue that option. Yes?
I'm curious on the community service element. Like, are there qualifiers in terms of what counts as community service?
We don't know.
Fair enough.
Yeah, we don't know yet, and I'll get to this in a minute, but the rules that CMS needs to issue to tell states basically how to implement and spell out things like what kinds of activities would count for community service. Those are not yet available, will not likely be released until June of next year. So it's just kind of a very tight timeline. Let me see if okay. Well, let me talk first about Ohio's waiver, and then we'll get to the timeline. So Ohio is one of 7 states that has a waiver pending at CMS to implement work requirements. Now, the state submitted this waiver prior to the passage of H.R. 1. So how Ohio was planning to implement work requirements is quite different from what is now required under federal law. I'll just say that we don't yet know how CMS is going to act on these waivers, but one thing we do know is that all states will have to comply with the federal requirements starting in January of 2027. So even if Ohio receives approval to implement its version of a work requirement, it will have to come into compliance with the federal rules in January. And then, as I noted, the timeline here is really tight. So states need to implement no later than January of 2027, although, again, some states can go early if they choose. But the rules implementing the requirements will not likely be issued by CMS until June of next year. And then importantly, states have to begin outreach to affected enrollees 3 months prior to the first look-back month. So if states are implementing in January of 2027, that first month that they'll be looking at to determine whether someone is in compliance with the new rules will be December of 2026, and then 3 months prior to that will be September. So states will get, the guidance will be released sometime, in June, and then states need to begin reaching out to enrollees in September about the new work requirements. Now, there is a provision that allows states to apply for a good faith waiver that would delay implementation till 2028. We're hearing, though, that through the grapevine that CMS is not likely to look favorably on those waivers. So I think most states need to be prepared to implement in January. So there are 2 states that have implemented work requirements. Arkansas implemented work requirements under the first Trump administration, so many years ago, and Georgia is the only state that currently has a work requirement waiver in place. But I do think the experience of both of these states highlights the challenges that all states are going to face as they move to implement these new federal requirements. So in Arkansas, despite an extensive outreach effort by the state to kind of inform and let consumers know about the new requirements, many people were confused and they didn't know that the new rules applied to them, nor did they even know what they needed to do to comply with the requirements. So outreach is going to be a significant challenge for states. I'll also note in Arkansas that they were able to data match, meaning they were able to use available data sources to confirm that 2/3 of the individuals subject to the new rules actually either met the requirements, meaning they were working, or they qualified for an exemption. But among the 1/3 of people who the state could not confirm compliance, 70% of them never reported. They didn't, again, know that they needed to report. They weren't able to navigate the system. We were able to determine after the fact that some of these people, many of these people, in fact, were actually working or qualified for an exemption. They just couldn't figure out how to navigate the process. And as a result, 18,000 people in Arkansas lost coverage. And I think in Georgia, the challenges there highlight both the cost associated with standing up the systems, making the systems changes that are going to be needed to verify compliance with these new requirements, but also, and in particular, the challenges that will happen when you condition eligibility at application. So Georgia is the only state to condition at application, and what they found is enrollment in their waiver program has been significantly lower than they anticipated. And when asked about, applicants were asked about the process after the fact, especially those who weren't able to make it into the program or to enroll in the program, again, navigating very difficult and challenging work requirement systems where they had to document and the systems were down or were complicated and it was difficult to understand, was named as the most significant challenge. So I will say I think Ohio is a little bit ahead of the game because of the work requirement waiver. The state has been doing some thinking and planning for this. So in that regard, I think the state is a little better positioned to implement, but nevertheless, it's going to be challenging for Ohio and for all states to implement. Okay, with that, I will turn it over to Adam.
All right, let me. Okay, thanks, Jen. And Amy, thank you very much for inviting me in the Health Policy Institute. I'm very happy to be here. And that was a very nice introduction. As part of that introduction, you probably knew I'm from North Carolina, and I also, in my previous life before I came to Georgetown, I was a bicycle mechanic. So I just wanted to raise the issue of the Wright brothers very briefly before my remarks. And I don't know if you're aware, you probably are, that in 2020 there was a truce between North Carolina and Ohio about who was going to claim the birthplace of aviation. And we had joint celebrations at the Huffman Prairie and at Kitty Hawk saying, we're both claiming. So, but then your governor, the next year, some of you know what's coming, issued a license plate that had the Wright brothers playing backwards and on the plate. And the North Carolinians could not resist. And they said, don't be mean to those people in Ohio. They weren't there. They don't know how it flew. So I'm just here to call for the truce again and say, let's have the truth. Let's both be the birthplace of aviation. I'm a bicycle mechanic, just like the Wright brothers. All right. Okay. I promise I'm going to talk about health policy, so. Okay. All right. So I'm so happy to be here with Jen because she covered so much already. So I have a bit of an easier task, but I am going to do a couple general points that will inform our discussion when we get to the question. So the first is, like all states, most of the federal money coming to Ohio, in this case, almost 70%, is through the Medicaid program. And why is that important? Because if you do a big cut in it, in that chunk of money, that health care that chunk of money is paying for doesn't go away. It's got to be paid for something else. And often there will be, state legislators need to, by law, balance their budgets. And so they're going to be, those budget decisions can ripple through other areas of the state budget, like, higher education and public health and stuff, or K through 12 and stuff like that. So let's go to the next slide. Boom. Oh, whoops, too far. All right. Whoops. All right, here we go. Okay, Jen talked about the total amount of cuts to the Medicaid program in H.R. 1 and the total coverage loss of $10 million. For Ohio, if you break it out, it's about $33 billion over the 10-year timeline, about a 13% overall cut, and the estimate is about 340,000 folks in Ohio losing coverage. So this is significant. Also, I'll note there have been some, you all have probably seen this, at UNC, my colleagues at down there at the Shep Center did a sort of listing of rural hospitals at risk, and 11 of them, they didn't say they were definitely going to close, but these are hospitals at risk. They said 11 of them were in Ohio. Okay, let's go. So one part of H.R. 1, which was presented as a way to ameliorate some of these cuts that we're going to be talking about, was this Rural Health Transformation Fund. And so it's interesting, and we're going to talk I'm going to talk in a little more detail about it, but the basics of it is that the overall amount is $50 billion of money that's dispersed equally each year over the next 5 years. And $25 billion of those dollars are distributed evenly between the states, which is going to have an interesting effect. I'll show you in my next slide, or the slide after that. And then the other $25 billion is distributed at the discretion of the CMS administrator, and depends on this application submitted by the state. And you all, I know your state agency has been soliciting comments and public input on what that application looks like. So 3 things to think about when we're talking about this Rural Health Fund. So the first is, this Rural Health Fund, the amount of money that's distributed, these decisions are non-reviewable. So the Secretary of CMS has the final authority to distribute that money, and there is no review in the courts or elsewhere as to that decision by Dr. Oz, who's the current administrator. The second part of it, this was not in the legislation creating this fund, but the CMS has decided that only 15% of those total payments to the state can go to providers, and that includes hospitals for provider payments. And then the final thing is, and we're going to talk about, is that when I read these applications and have looked at the law, there's a real tension between really great ideas about improving rural health and the politics around this fund. So to get to the politics, first of all, you've got the $33 billion in cuts over 10 years that are estimated for Ohio, but the share of the rural fund that Ohio is estimated to get is $1 billion over the next 5 years. Now, it could be a little higher than that, could be a little lower, depending on that discretionary authority on that second half of the fund, but it is in no way a way to make up for the full amount of those cuts, and those cuts are ongoing. So that's just, something to, when people talk about this fund, to keep in mind how much smaller it is than the estimated cuts. The second thing is, and this is so interesting, the first half of the fund, remember, it's distributed evenly between the states. And so that means a state like Idaho, who has 2 million people in it, is going to get exactly the same $100 million a year as a state like Ohio, who has almost 12 million people in it. And where does that money go farther? It goes farther in these smaller population states. And again, that decision has been made. It's not reviewable. Okay, so the thing I think that's so interesting about this is that there are really great examples in the discussion in the state application that CMS has issued of improving rural health. There's great ideas about provider retention and training in rural areas, and doing more population health infrastructure ideas, what I was talking with Amy about earlier, and quality of care initiatives. So these are great ideas. But there's also this political stuff in there. They say, well, we'll give you a better score if you pass some of these laws that we like on CON, certificate of need laws, or if you mess around with the SNAP, what people can spend their SNAP benefits on, or if you allow more short-term limited benefit sort of skimpy health plans, we're going to give you more points for doing that. So I think as we go forward with this, one thing that I'm going to be looking for, and others are too, is what do these where does this money go? Is it looking like it's more being allocated on some of these political requirements, or is it going to really great ideas on rural health care? And by the way, none of those political requirements were in the original legislation. So now I'm going to finish up now. So how was this presented? So this fund was presented as a rural hospital fund. This was going to save our rural hospitals, okay? And in fact, I was pulling some of the stories from Ohio a month ago from your hospital association was quoted in there, and they were praising this fund and saying Ohio's rural hospitals are going to get $1.3 billion over 5 years. It establishes new financial resources. But that's not what is in this application. That's not what this is about. So the politics, and Ohio is not alone in thinking that's what it was for. That was what it was generally presented as in Washington. So we're going to have to see how that works in practice. Okay, so finally, I just want to sort of echo what Jem was saying. I think as we go forward, we've got this, there's a lot of talk about this fund. It's a small amount compared to the cuts, but it's really up to us at the state level as we're moving forward to implement work requirements, some of these other changes, and to deal with, as policymakers have to deal with the impact of these cuts, to document what's happening on the ground so that policymakers have the best information as to how the state is, able to deal with this, especially, stories of individuals, families, and providers. I know you have another session, right, on this, I think, later in the day about this. So it's no, huge surprise about that. So thank you very much, and I look forward to your questions.
I have a few questions just to get us started, but if you have a question, we have Nick and Brian with microphones, and they will happily come to you. So just raise your hand if you have a question you'd like to pose. All right, so Jen, I have a follow-up question related to the work requirements. So could you talk a little bit more about how states will monitor compliance with the work requirements? Like, I know that there's at the point of initial application, and then there's the point of at redetermination, which will now happen every 6 months rather than every year, but it's a monthly work requirement. So will people have to somehow document and report their work activities on a monthly basis, or will it not be until redetermination?
Yeah, that's a great question. So it is a monthly requirement, but the way states will verify, there is some flexibility as to how states implement the verification requirements. So at application, the state will have to look back 1 to 3 consecutive months immediately preceding the application month. So if someone applies in October, the state has to look back at least to September to see if the individual met the work requirements or qualified for an exemption in September. But the state could also look back September, August, and July. So, there is some flexibility. Obviously, looking back 1 month will make it easier for individuals to comply than looking back 3 months. And then at renewal, which again, you noted is every 6 months, but states can decide to verify eligibility more frequently than 6 months. But assuming a state chooses a 6-month period, the state needs to look back 1 month between eligibility determinations. So, but the state could look back more. So the state could decide to look back and require compliance in all months, all 6 months, or just one of the 6 months between the eligibility determinations.
Okay.
Does that make sense?
Yes.
Okay, good.
I think so. This is a question for either of you. What are some of the state policy decisions that need to be made? I mean, Adam, you've talked about related to the Rural Health Transformation Fund. And of course, we talked about the work requirements, but are there other state decisions that will need to be made over the next several years?
I mean, yes, you have to make I think those are the two biggies right now is the work requirements, because you have to get ready. And I think we were talking about earlier how you're going to have to make those soon, right? Yeah, you have to really, this isn't something that's happening later. So those are two major ones. And I think, from my perspective, just overall, I think states are going to have to start to think about how they're going to provide care for people who are removed from the program, and that do you go back to the bad old days, do you go back to the days where you're paying for much more mental health services, and especially at the county level, are counties going to be paying for more? I mean, I think policymakers are going to have to be anticipating that we're going to have a lot more people who need care, and we may have to come up with money from other sources. So I think that's the other one.
And am I recalling correctly that North Carolina is one of the states that's already making some cuts? Yeah, that's a great point. So North Carolina is already starting to make cuts in their Medicaid reimbursement rate. It's partly due to state budget constraints, but they're also citing that they are worried about the coming reductions in their provider taxes, and then and other federal funding. So they're cutting provider reimbursement rates? Yes. Okay. Yes. Yeah. So when states are looking to make up the loss of, say, provider taxes or franchise fees in the future, what are their options in terms of what can be reduced in order to fill those gaps?
I've been talking.
Okay.
I can take a stab at it, but go ahead.
I'll call on Jen.
Yeah.
Call on Jen.
Okay. Yeah. Well, if you remember Adam's slide, his first slide, right, that showed the sources of federal funding. Well, right. Like if we're cutting the Medicaid funds that come to the state, there are limited options. So a state could choose to raise taxes. I think that's somewhat unlikely, but some states may choose to do that. They could pull funding from other sources, but where are you going to pull? Higher education, corrections? I mean, these are all program areas that need the funding that they have. So yes, you could pull from these other areas, but more likely you'll have to make cuts to the Medicaid program. So you'll have to look at eligibility, provider rates, which we're hearing about. I think that's likely going to be a place where many states start because the law is already ratcheting back on eligibility. So if a state were to go deeper, that would cut even more people off the Medicaid rolls. So I think provider payments, benefit cuts is also another likely area that states will look to. So to cut benefits, perhaps like dental benefits that they may be providing to adults. Another area, although the law explicitly does not target long-term care with any provisions, except, well, it does include a waiver to allow more people to access home and community-based services. But home and community-based services are an optional service for state Medicaid programs, and they are also the most expensive services to provide. So that if a state needs to find a significant source of funds, that may be an area where they cut.
Yes, and our Ohio Medicaid Basics has a list of all of the mandatory services and the optional services that Ohio is covering right now. So if you're interested in learning a little bit more about what's on that list of items that could be cut, you can look at that document. Yeah. And, okay, go ahead.
I was just going to, you can see why I'm so happy to be up here with Jen because she's so knowledgeable. But I think, just to add to what you were saying, I think the magnitude of these cuts is significantly larger than the usual state debate that I'm familiar with about cutting Medicaid. Like when I worked at the state level, I went through lots of debates about cutting state Medicaid, and we'd cut adult dental, and then, you'd save however many millions of dollars, and that would be that. But this, $33 billion is a lot more than these, so it's going to be a bigger discussion, I think, than we've had in the past.
And I'll just add to that, sorry. But, and this is happening actually as state budget situations are tightening because of economic pressures and others pressures. So, states were pretty flush with revenue and cash during the pandemic because of the extra federal funds that went to states, but we're not in that environment anymore. So states are already making adjustments and having to deal with being in a situation of having less revenue. And so then these cuts are hitting on top of that.
Mm-hmm. All right. Anyone have any questions? We have one. Oh, we have one there and one there.
So I remember I think it was your slide deck that had the portions about the things that are not necessarily in the language that's passed, but preferential treatment could be given to states that cut unrelated programs and things like that. Do either of you have any idea what that landscape looks like for Ohio or for other states that are preemptively trying to get on the good side for these rural funding opportunities?
Mm-hmm. Yeah, and so I have seen, I'm trying to track this around the country. There are some states that are talking about having a special legislative session to, implement maybe if they haven't done some of these policy changes that that are they're being asked to do in that application. So they're thinking about doing that. I know that you all, I think, have already limited your SNAP benefits, right, for things that are non-nutritious, according to some folks. Or yes, they are, but I always think of Charlie Bucket going to the Willy Wonka's chocolate factory. He's like, I've never had a chocolate bar before, but anyway. But so y'all have done that, but I don't know where y'all are with CON. I think every state debates on that. So do y'all? I don't know if y'all even have it here. Do y'all?
No.
You don't use it CON here. And then the limited health plans. I think
facilities?
most states have more restrictions on them than are contemplated in there. So that might be one place.
Is it certificate of need for hospitals or nursing facilities or both?
Both.
Okay, so we don't have it for hospitals, but we do have it for nursing facilities.
Okay, yeah. If you got rid of it for nursing facilities, that might give you a few more points on your scale. I mean, I have to say, I think it is. I don't know, Jen, but I cannot remember when. Every federal program there is some, state, please do this, please do that, but coupling a grant like this with these state policy changes that are not even in the federal law is just very unusual.
Mm-hmm. So, yes, go ahead.
Excuse me. I have not read H.R. 1, Big Beautiful Bill. So I'm just assuming that you're giving us the highlights of the Medicaid part. So I'm wondering, has anyone done research about the employment part? Because and I know you said that if people have a high unemployment rate in their county, they can be exempt, but wouldn't that sort of incentivize people to not maybe get jobs in their area? I don't know, but has anyone done research on how that will impact the economy of those counties? And I have a lot of questions, but I'll just stick with that one.
Yeah, so when it comes to employment, I think one thing that I'll just note is that we've done analysis of the population that's likely going to be subject to these new work requirements to just understand who they are and their current work status. What we found is that over half, actually over 6 in 10 of individuals subject to the new requirements are already either working 80 or more hours a month or are in school. And then an additional 17% are not meeting those requirements but appear to qualify for an exemption. So they report that they're not working or not working 80 or more hours because of caregiving responsibilities or because of illness or disability. So we're talking about a really small sliver of people who may not be meeting the requirements. And I will note this also includes quite a few people who are ages 50 to 64 who report that they're not currently working because they retired. So these are people who worked for years and are now maybe not working for various reasons. But so we've got this new work requirement in place despite the fact that most people are already working. The problem is that everyone is at risk of losing coverage because of the reporting requirements, right? So someone who works at a gig job, who drives for Lyft or Uber or, is part of the gig economy may not have a pay stub from an employer that they can submit to document that they actually were working. So I think this is going to be really challenging. I will also say that states have been very successful and have had some successful approaches to encourage work. So workforce supports for people on Medicaid. Mm-hmm. That is not included as part of this law. And in fact, the Trump administration has indicated that it is eliminating approval of waivers that some states have had obtained to provide kind of workforce supports to kind of help and bridge the gap or the challenges that some people may face with moving into a work setting. So I will say to answer your question specifically about whether there's anything in here in the law to support work, it's a huge law. And there are lots of tax incentives that go well beyond Medicaid that may or may not have an effect on work in specific communities. So I can't answer your larger question, but hopefully some of that context was helpful.
Back earlier this year, HPIO produced a series of briefs that we called the 2025 Medicaid Expansion Study. Now, those briefs were focused on if Medicaid expansion were eliminated, what would that mean in terms of coverage losses? And then we also looked at state budgetary impacts and economic impacts. So to your question, we did examine that in one of the briefs. Now, as I said earlier, Medicaid expansion has not been eliminated, at least not now. That FMAP can always be, the federal match can always be reduced later, but it hasn't yet. So that will remain in place. But that analysis we did around economic impact is still relevant because if you're taking $33 billion over 10 years out of a state's economy, it will have impacts. It'll have impacts in terms of jobs, and not just jobs in healthcare industry or, in insurance companies, but all the jobs that are kind of spun off of that economic activity. So people who work in like restaurants around a hospital system, or people who provide services to provider organizations. So I would encourage you to take a look at that to at least get a sense of what those economic impacts might be. HPIO has also done several pieces recently on HR1 and the interplay with the state budget. There's a link. Do we have a link in the program or? Oh, there it is. All right. There's a QR code up on the slide right now to get access to those publications. We did something on work requirements, and then we did something just kind of overall on the major provisions of HR1 and in the state budget. So I'd encourage you to take a look at those too. And I think that is all the time we have. Do you have a question? No. Okay, you don't have a question. Okay, I think that's all the time we have for this afternoon. Please join me in thanking Jen. A little while ago, when I last checked, we still had some folks who had signed up for CE but had not signed in at the registration table, and we know you were here because we know you. So just checking in at the registration table is not enough. You have to go to the actual CE table where there's pink, blue, and purple pieces of paper. So look for that and make sure you sign in so that you get your credit. Right now we have some time for you to mix and mingle, to go visit the posters, and then make your way to your next session. Enjoy the afternoon.
All right, very nice.